OnlyTrans ultrasound guided lumbar puncture. In this short video, I am going to demonstrate lumbar puncture using the only transverse or axial ultrasound scanning using the triangulation technique that simplifies the complex anatomical challenges posed by distorted anatomy. By focusing on one vertebral segment, ultrasound guided lumbar puncture becomes precise, manageable and repeatable, even in anatomically challenging cases. Scoliosis often distorts the curvature of the spine, making it difficult to rely on palpation or imaging across multiple vertebral levels. Triangulation only targets one segment, eliminating the need to account for global spinal distortions. The spinal canal remains aligned relative to the spinous process within the selected segment regardless of curvature. The OnlyTrans method eliminates the need for longitudinal or sagittal imaging. Focus entirely on the transverse plane to safely and effectively guide your needle. Why does this method work? Well, it plays down the historical dogma of cord trauma. Concerned about hitting the cord? Don't be. If you're low enough, aiming at L3 to S1 level, the cord and conus are out of the way. In adults, the conus really descends below L2 level, giving you a wide safety margin below. Transverse imaging simplifies the anatomy. As you can see on the ultrasound on the left, the spinous process appears as a hyperechoic midline structure. The transverse processes and paraspinal muscles symmetrically flank the spinal canal. The needle tip is visible in real time as it approaches and crosses the interspinous ligament. The sagittal view, as on the right, may introduce confusion. The adjacent levels or scoliosis can give misleading cues, potentially misdirecting the needle path. The core principle of triangulation. Triangulation leverages the inherent geometry of the vertebral segment. The spinal canal lies directly anterior to the spinous process. It is symmetrically positioned between the transverse processes and paraspinal muscles. The OnlyTrans method streamlines your approach by focusing solely on transverse scanning with your ultrasound probe. Conveniently, TRANS also highlights the three critical elements to visualize when using the triangulation method. TRA stands for transverse processes. You identify these to locate your landmarks. N stands for needle tip and trajectory. This ensures you're on track. And S, the spinous process. It marks your midline target. With the OnlyTrans method, precision and safety are always within reach. You can see the bottom left showing the spinous process and the transverse processes. This is a CT guided lumbar puncture showing the needle trajectory, equidistant bisecting the transverse processes and paraspinal muscles and entering the spinal canal. Position the patient either sitting up and hunched over or lying in the lateral decubitus position, which is necessary for measuring opening pressures. In both cases, maintaining good lumbar flexion is the key. Flexing the lumbar spine maximizes the space between the spinous processes, creating a wider window for needle entry and minimizing the likelihood of contacting bone. A linear ultrasound probe usually provides sufficient resolution for guiding lumbar punctures. However, in patients with higher BMI or when deeper anatomical visualization is needed, a curvilinear probe can offer superior depth penetration, making it easier to identify key landmarks and ensuring a safer, more precise procedure. Anatomical triangulation principle. Here is the anatomical evidence superbly demonstrated in this animation. Please note the spinal canal, the spinous process, and the transverse processes. We base our approach on a fundamental anatomical principle. This is that the spinal canal is located directly anterior to the spinous process and precisely equidistant between the transverse processes and paraspinal muscles. This works for individual segments. Scoliosis ceases to become a problem. Landmarks. Identify your key landmarks on ultrasound. Use the transverse view to locate the spinous process, seen as a midline shadow or hyperechoic structure, the transverse processes, symmetrical structures on either side of the spinous process, and the paraspinal muscles surrounding hypoechoic areas flanking the transverse processes. Needle entry should be perpendicular to the skin. A perpendicular trajectory ensures a straight path through the interspinal space into the spinal canal, minimizing the risk of lateral deviation. Angling the needle introduces complexity and increases the risk of missing the midline or encountering bone. My tips: with the probe in the transverse plane, gently rock the probe cranially and caudally. This maneuver reveals the needle tip as it aligns with the spinous process or sits just above or below it. Real-time visualization ensures precise adjustments to stay on course. Compare the two transverse ultrasound views of the lumbar spine on the right. In the upper image, the spinous process appears directly in your path. However, by targeting just a few millimeters above or below this bony landmark, you can guide the needle into the interspinous space. Note how in the lower image, the spinous process is no longer blocking the way. Even if your needle does brush the tip of the spinous process, there is little cause for concern. Simply adjust your trajectory slightly, angling more cranially or caudally, and then advance safely into the interspinous space. The triangulation technique relies on three core ultrasound landmarks: your skin entry point, marked after identifying the midline and the trajectory. The needle trajectory visualizes the path towards the spinous process tip, and the symmetry of the transverse processes and paraspinal muscles, confirmed on ultrasound to ensure the needle bisects the transverse process precisely. By aligning these elements, the needle trajectory is guaranteed to intersect the spinal canal. Variability in the lumbar curvature and surface anatomy is accounted for. Successful entry into the spinal canal is achieved with minimal complications. See the tip of my needle going immediately behind the spinous process, and it's perpendicular to the skin. The angulation is perfect, and we will get into that spinal canal. And here you can see the trajectory on the right. I found charting my course with local anesthetic invaluable. I always begin by mapping out my needle trajectory through local anesthetic infiltration. Remember, the patient's superficial midline doesn't always match the vertebral midline, so this step helps me line everything up correctly. Here you see me infiltrating just posterior to the spinous process. Skin and subcutaneous tissues are very forgiving, so there's minimal risk of causing trauma or bleeding. By doing this, I effectively register my skin entry point, the trajectory, and the vertebral level before placing my needle. Typically, I use about 8 milliliters of lignocaine, reserving a couple of milliliters for any deeper structures if necessary. This approach not only ensures precise needle placement, but also makes the entire procedure smoother for both the patient and the operator. Here I've positioned the patient using lumbar flexion, the fetal position, and this opens up the interspinous space. I've cleaned and prepped the patient. I then obtain my transverse ultrasound view, identifying the spinous process, the transverse processes, and the paraspinal muscles. I confirm the symmetry of these structures. I mark my skin entry point. I mark the midline at the level of the interspinous space, and then I infiltrate my local anesthetic. Here I will use a 22 gauge needle, which is sufficient for most lumbar punctures and comes in various lengths. As I advance under ultrasound guidance, I expect a point where the needle tip disappears on the screen, hidden by the acoustic shadow of the bone. Rather than worrying at this stage, I continue my planned trajectory, confident I'm aiming for the canal, and I've kept low enough to avoid the spinal cord. Once in the deeper tissue, I rely on tactile feedback, first feeling the firm grit of the dura, and then the distinct give when the dura is pierced. I remove the stylet to check for CSF flow. If there's none, I rotate the bevel. Still no CSF, I reinsert the stylet and advance a few millimeters further. In this area of the spine, I know that beyond the dura lie only the posterior vertebral body or the intervertebral discs. No critical structures that could be severely harmed. Why triangulation? Well, because of variable anatomy. Patient spinal curvatures and body habitus vary significantly, making surface landmarks unreliable. Factors like scoliosis, obesity, or muscularity can obscure traditional palpation-based guidance. Ultrasound provides real-time visualization of spinal structures, enabling precise adjustments. Triangulation integrates ultrasound findings with anatomical geometry to guide the needle trajectory. By prioritizing the transverse view and focusing on a single vertebral segment, distorted anatomy becomes irrelevant. The local alignment of the spinal canal is all that matters. Needle placement is simplified. A perpendicular approach minimizes complexity. Ultrasound clarity is maximized. Real-time adjustments ensure precision. This streamlined approach ensures the spinal canal is accessed with confidence and reduces the cognitive load of managing broader anatomical variations like scoliosis. So, I'm going to reiterate the key components of triangulation. Identify the midline. Use the transverse ultrasound view to locate the spinous process. This structure anchors your midline, ensuring needle alignment with the spinal canal. Define the symmetry. On the transverse view, identify the transverse processes and paraspinal muscles on both sides. The spinal canal is located halfway between these structures. Symmetry of these landmarks ensures needle trajectory remains in the correct anatomical plane. Plan the needle trajectory. Direct the needle trajectory towards the tip of the spinous process. The ultrasound-guided skin entry point and the needle trajectory should be planned so that the needle bisects the transverse processes precisely in the middle. The needle's path is directed towards the midline of the spinal canal. Thank you for listening to this lecture. Please leave any questions or feedback and I shall endeavour to reply to each of you.